Today we're going to talk about preterm birth. Preterm birth is an important topic because it is the leading cause of neonatal mortality in the United States. In this mini video lecture, we are going to highlight some of the general principles of preterm birth and provide you with a framework for which to expand your knowledge. So we're going to start with the definition of preterm birth. So the definition is typically what we describe as birth prior to 37 weeks gestation. Others describe it as before 259 days from the last menstrual period. Alternatively, it has been described as birth between 20 to 24 weeks and 36 weeks and 6 days of gestation. The cutoff of 20 weeks gestation was previously used because this is when quickening was first felt. Alternatively, if gestational age is unknown, a birth weight of greater than 500 grams has previously been used to define fetal viability. When we talk about preterm birth, we can classify it into two different categories. One is spontaneous preterm birth, and two is indicated preterm birth. Spontaneous preterm birth includes preterm labor and preterm premature rupture of membranes. Indicated preterm birth includes all deliveries secondary to maternal or fetal indication. Indicated preterm birth includes, as we stated before, maternal indications like maternal diseases and fetal indications. Common maternal diseases leading to preterm birth include cardiac disease, diabetes. Common fetal indications include growth restriction, preeclampsia, placental abruption, fetal distress, and fetal demise. 25% of all preterm births are secondary to indicated preterm birth. The remaining 75% are attributed to spontaneous preterm birth. This can further be broken down in that 45% are due to preterm labor, 30% due to PPROM. In the United States, the rate of preterm birth is approximately 14%. The rate of preterm birth has risen since the 1990s, and this has been attributed to a few different factors. Number one, an increase in the number of late preterm births. Number two, an increase in the number of multiple gestation. And number three, an increase in maternal age. So, when we compare term to preterm birth, there appears to be a common final pathway. And Creasy described this common final pathway as the common pathway of parturition. It includes three different key factors. One is an increase in myometrial contractility, two is cervical ripening, and three is membrane rupture. So it appears that the difference between term and preterm labor is the stimulation or the activation of this common final pathway. So in preterm birth, there has been several different mechanisms hypothesized to stimulate this process. These include, one, infection and inflammation. So infections like a urinary tract infection, pyelonephritis, pneumonia, genital tract infections, and subclinical infections have all been hypothesized to cause a systemic inflammatory process thought to stimulate labor. Two, uteroplacental vascular disease and decidual hemorrhage. So here we're talking about retroplacental clot or hematoma or even a placental abruption causing preterm labor and delivery. Three, maternal and fetal stress. So as far as maternal stress, we're looking at both physical and emotional stress. Fetal stress caused by a hostile uterine environment. Four, uterine overdistension. Here we see preterm labor caused by uterine overdistension in the settings of polyhydramnios and multiple gestations. Number five, an allergic phenomena similar to infection and inflammation. In this case, an allergen would stimulate an immunologic response causing a systemic inflammatory process. Six, cervical disorders like cervical incompetence and congenital anomalies predisposing someone to preterm labor. And seven, hormonal disorders. So here in the hormonal disorders, we're talking about a suspended progesterone action. So it has been shown in many species that a progesterone withdrawal occurs before spontaneous labor. However, this has not been shown in humans. However, there has been demonstrated a functional progesterone withdrawal that occurs locally at the intrauterine tissues in both term and preterm birth. The progesterone theory has been thought of secondary to the use of antiprogestins for the induction of labor. Like we said before, an infection like genital tract infection and colonization could predispose somebody to preterm labor. Non-white race, multiple gestation secondary to uterine overdistension, bleeding in the second trimester, low pre-pregnancy weight as a function of maternal stress or maternal malnutrition, and most importantly, a history of previous spontaneous preterm birth. So as far as the diagnosis of preterm labor, it's not an easy one to make, and it's not easily defined, as you can see here. So classically, it's defined as contractions plus cervical dilation. Others have defined it as contraction frequency greater than 6 per hour, cervical dilation of greater than or equal to 3 centimeters, some sources say 2 centimeters, cervical effacement of 80%, and ruptured membranes or vaginal bleeding. So when we diagnose somebody with preterm labor, now we have to think about the treatment and the management. So as far as the treatment, there are 2 main treatment goals. Number 1 being transfer the mother to an appropriate hospital for delivery, and number 2 being the administration of antenatal corticosteroids. So now when we look at the management, as we stated before, we want to administer antenatal corticosteroid for fetal lung development, administer tocolytic therapy to help provide us a window in which to administer these corticosteroids. We would like to start antibiotics for group B strep prophylaxis, since group B strep infection is more prevalent in a preterm population versus a term population, and initiate magnesium sulfate for neuroprotection. So this little mini lecture has provided you with a basic outline of preterm birth. Here are the reading assignments. Please review all the materials and come prepared to Tuesday morning conference to discuss different patient presentations and their management. Thank you.